Welcome back to my channel, and today we are going to start with the active components of the removable orthodontic appliances. Now they are the components of the appliance which exert force. So the retentive components are for the retention purposes and the active components are for actual force or to bring about the necessary tooth movement. So the active component of the removable appliance is which applies force on the tooth to bring about necessary tooth movement. Okay, so active components of a removable orthodontic appliance are as follows. They are bows, springs, screws and elastics. Okay, so the active components of the removable orthodontic appliances are bows, springs, screws, elastics. Okay, so we are going to study in detail bows, in detail springs, in detail screws and in detail elastics. So the active components of the removable orthodontic appliances are which exert force to bring about necessary tooth movement. Okay, now we are going to start with bows. Bows are active components that are mostly used for incisor retraction. Okay, so bows are usually used for the incisal retraction. Okay, for the incisal retraction mostly bows are used. Okay, so if you want to make notes, you can write bows, and bows are used for incisor retraction. Okay, there there are various type of bows routinely used by the orthodontists. The following is a list of commonly used labial bows. So usually you get to ask how many types of labial bows are there, or what are the types of labial bow. So first is the short labial bow, second is the long labial bow, third is the split labial bow, fourth is the reverse labial bow, Roberts retractors, Mills retractors, high labial bow with apron springs, and fitted labial retractor or fitted labial bow. Okay, short labial bow, long labial bow, split labial bow, reverse labial bow, Roberts retractors, Miller's retractors, high labial bow with apron springs, and fitted labial bow. Okay, so bows are mainly for the incisal retraction. Okay, bows are mainly for the incisal retraction. Okay, so first we will start with the short labial bow. Okay, short labial bow, this is a type of labial bow constructed using a 0.7 wire. Again, 0.7 mm wire is used for the construction of this short labial bow. Okay, and the short labial bow consists of a bow that makes contact with the most prominent labial teeth and two loops that end as a retentive arm on the distals to the canine. Okay, so if you can see, it is touching the most prominent tooth and then it goes to the canine, makes a loop and ends at the palate. Okay, so this type of labial bow is very stiff and exhibits low flexibility. So the advantages are that it retracts the incisors, but the disadvantage is that it is very stiff and it is having low flexibility. Okay, it is very stiff and it has low flexibility. Okay, now the two loops end as retentive arms distal to canines. You can see that these are the loops which he's talking about, U loops. Okay, now thus they are indicated only in case of minor overjet. If there is a very minor overjet, that can be reduced using this short labial bow, and reduction and anterior space closure. If there is a space in the anteriors, if there is a space, this space closure can be done using this short labial bow, which reduces the overjet. Okay, now the short labial bow can be used for the purpose of retention again and termination of fixed orthodontic therapy. Okay, now the short labial bow is activated by pressing U loops. Okay, if you press the U loops, the labial bow is activated. The activation should be such that the labial bow is displaced palatally by 1 mm. Okay, so the activation should be such that the labial bow is displaced palatally. Okay, 1 mm. That's all. So that is about the short labial bow. Now coming and moving forward to the long labial bow. This long labial bow is similar to short labial bow, but except that it extends from one first premolar to the opposite first premolar. This was short was from canine to canine, right? And this long labial bow is from premolar to premolar. Okay, premolar to premolar. Okay, now the distal arms of the U loops are adapted over occlusal rims. Sorry. The distal arms of the U loops are adapted over the occlusal embrasure. This is the occlusal embrasure. Okay, and then they get embedded into the acrylic plate. The indications of the long labial bow are minor anterior space closure, as we discussed earlier. Same anterior space closure, overjet, closure of space of the distal to the canine, guidance of canine during canine retraction for retraction using palatal retractors as a retaining device, and activation is similar to that described of the short labial bow. Again, you press the U loops, 1 mm displacement of the retentive arms is the activation of the long labial bow as well. Uses of the long labial bow include minor space closure, overjet reduction, and space distal to canine is also closed. Okay, and the activation is similar to okay, next is a modified form of long labial bow can be made by soldering distal arm of the U loop on the bridge of Adam's clasp. Okay, distal arm of the U loop on the bridge of the Adam's clasp. On the bridge of the Adam's clasp. Now we are going to see how that is. That is nothing but your split labial bow. Okay, this split labial bow that is split in the middle. This is the split labial bow that is split in the middle. Okay, now this labial bow is split in the middle, resulting in two separate buccal arms. Okay, so you can see that there are two separate buccal arms, each having their own U loop. Okay, this type of labial bow exhibits increased flexibility as compared to the conventional short labial bows. Okay, the split labial bow is used for anterior retraction. A modified form of split labial bow can be used for the closure of medial diastema. Okay, it can be used for the closure of medial diastema. In this form, free ends of the buccal arms are made to hook onto the distal surface of the opposite central incisor. The split labial bow is activated by pressing the U loops 1 to 2 mm at a time. Okay, now in this form, free end of the buccal arms, so the free ends of the buccal arms are made to hook onto the distal surface of the opposite central incisor. Okay, that is the main function or the working principle. Okay, now moving forward with the reverse labial bow. Now we saw the short labial bow, the long labial bow. Now we're seeing this. Also we saw the split labial bow. Okay, we saw the split labial bow. Okay, I'm so sorry, split labial bow. Now we're seeing the reverse labial bow. Now what does the reverse labial bow has to say? This is also called as the reverse loop labial bow. Okay, here the U loops are placed distal to the canine. U loops are placed distal to the canine. So here somewhere you get the U loops. Here, distal to the canine. Okay, and free ends of the U loops are adapted occlusally. Free ends of the U loop are adapted occlusally. Okay, between the first premolar and the canine. The longer span of the wire is incorporated. The bow exhibits increased flexibility. The bow exhibits increased flexibility. Indication for uses are similar to that of the short labial bow. The activation of the labial bow is done in two steps. First, the U loop is opened. The U loop is opened. Okay. This results in lowering the labial bow in the incisal region and compensating the bend, and then it is given at the base of U loop to maintain a proper level of the bow. Simple. Now Robert's retractor. Robert's retractors are labial bow made up of thin gauge stainless steel wire having a coil of 3 internal diameter mesial to that of canine. The use of thin 0.5 mm diameter wire along the increased wire length due to the incorporation of a coil makes the labial bow highly flexible. Okay, so what this is saying is that this is the Roberts retractors, which are these things which make the labial bow very flexible. Okay, it makes, okay, and this is your reverse labial bow, which has this U loop which can be opened and closed. Okay, now the next one is this Roberts retractors. These are made up of the 0.5 mm wire. Okay, 0.5 mm wire and in diameter with increased wire length due to incorporation of a coil. See, can you see, this is a coil. This is how it is going. Sorry, this is how it will go. It's going to coil over and come out. Okay, so that is how the Roberts retractor looks like. So it is a coil of 3 mm. 3 mm is the coil. 3 mm of the internal diameter of the coil, mesial to the canine. It is a little bit mesial to the canine. Okay, and along the increased, due to the incorporation of a coil, it makes it more flexible. As a very thin wire is used to fabrication, the bow is highly flexible and lacks stability. So the main disadvantage of this Roberts retractor is that it does not have stability. Okay, lacks stability. Now this part of the retractor is supposed to be 0.5 mm. The Roberts retractor is indicated in patients having severe anterior proclination. So people who have severe anterior proclination, for them this Roberts retractors can be used with an overjet of about more than 4 mm. Okay, as the bow is highly flexible, it generates lighter forces and they can be used in adult patients whom lighter forces are desirable. Okay, now Miller's retractors. Mills retractors, this is a labial bow having an extensive looping. Okay, this has an extensive looping. Mills retractors is having an extensive looping. Okay, now the wire so as to increase again flexibility and the range of action. Okay, now Mills retractors or extended labial bows, as sometimes called, indicated in patients with large overjet. The disadvantage is it includes difficulty in construction and poor patient acceptance. Why? It is because of the complex design of the bow. So patients get scared, oh my god, what is this? So that's why they are a bit hesitant with this Mills retractors. Now moving forward to the high labial bow with apron springs. It consists of a heavy wire of 0.9 mm thickness. Okay, so this is made using 0.9 mm wire. Okay, now 0.9 mm wire in and which extends into the buccal vestibule. Apron spring is made up of 0.4 mm wire and is attached to the high labial bow. Okay, 0.4 mm wire and is attached to the high labial bow. Okay, now this type of labial bow is highly flexible and is used in cases of large overjet, as where as very light forces are generated by them. Same, they are also used for in geriatric patients or for light, used in cases of large overjet as light forces are generated by them. The apron spring is an active component that is achieved by bending it towards the teeth. It is highly flexible. Activation up to 3 mm can be done. Okay, disadvantage includes difficulty in construction and soft tissue injury risk is also there. Okay, now next is the fitted labial bow. In this type of labial bow, this type of labial bow is when the wire is adapted to conform the contours of the labial surface. So the wire is adapted to contour the labial surface. The U loop is usually small. The fitted labial bow cannot be used to bring about active tooth movement. They are used as retainers at the completion of fixed orthodontic therapy. Okay, so that's all for this video. We have only discussed the bow part. In this, spring, screw and elastic is in the upcoming videos. Thank you for watching. Stick with me for the other parts, which include your springs, screws and elastics. Thank you for watching. If you like, subscribe to my channel and comment down if you don't like my teaching. Thank you.